Hello everyone. I was just finishing up an email while I was waiting for someone to show up. I'm back from Montana. I was there for a critical care conference. That was an outdoor conference, which was amazing, Bozeman, Montana. And I don't feel like doing anything today because I have to go to work tomorrow. I've been gone for 4 days and then I have to work for 4 days. This is my only day off. So I'm just chilling, and I just realized that I went live probably in one of the worst possible times you can go live, which is a Friday afternoon, but we'll see what happens. I start my EMT in September, sponsored by the fire department. Any advice? Yeah, go to an EMT school not sponsored by a fire department. That sounds salty, but if you have I guess if you're going to be a firefighter and they're, having you get your EMT, that's fine. But if you're just wanting to become an EMT and you can get it without having to go to any sort of agency-sponsored program, that's what I recommend that you do. Agency-sponsored programs are they're trying to get you to work for their agency and be the type of EMT or paramedic that works within that agency. And that doesn't necessarily mean that you're going to be educated beyond what works for the registry and their protocols. But I get it, though. I mean, a lot of times these agencies will put you through. You don't have to pay anything. At the most, you might have to sign a contract saying that you'll work for them for 2 years or something like that. I get it. Hello there from Wisconsin. Hello back to you. I have an uncle that lives in Wisconsin. He lives in Madison, and he has his doctorate and is a professor at the University of Wisconsin. Hello from Iowa. Hello back to you in Iowa. I was invited to speak at a conference, I think it was in Iowa, last March, but I hadn't spoken anywhere yet, and I was just kind of trying to get my sea legs as far as speaking engagements went, and I didn't want to fail all the way in Iowa. Since then, I've spoken at various conferences and have gotten a lot more confident. I'm taking the National Registry in an hour, feeling pretty prepared. Do you have any big advice? The biggest thing is to make sure you read the questions from front to back. Don't be too trigger happy. Make sure you read the questions. Make sure that you understand whether you can stabilize a patient or if only like an operating room or a cath lab can stabilize a patient. I don't have too much feedback yet on the new format, so other than that, I would recommend getting a little bit of peace and quiet before you go in there. My agency has just gotten heparin for pre-hospital STEMI. Why is it not advisable for us to use for PE? Because you would need to use like TPA or something like that for PE, not heparin. Doing your EMT with ATEC, a private ambulance company. I just get to work for the department simultaneously. Yeah, I mean, I get it. I do get it. I don't think there's really any evidence for benefit for heparin, pre-hospital administration of heparin for MI, for STEMI. Interfacility or 911 as a new EMT, the one that you want to do. I don't necessarily think interfacility prepares you for 911. It's an entirely different thing, and it's mostly palliative and holistic. I mean, it definitely, honing that palliative care and that holistic type of care is definitely important. But I don't think that you need to pay tribute to people's demands that you get that experience through IFT. Or interfacility. There are people who can go to 911 and function just fine. I didn't work a day in interfacility. I just started 911. There is something to be said, though, for people learning how to take care of people holistically, because medicine is first and foremost holistics. Yeah, interfacility and 911 are just two different paradigms. And you can learn. There are things to learn from interfacility, but I don't think that you need to have that experience to function well in 911. Do you see a difference between fire-based and third service when it comes to holistic care? I see a huge difference between any healthcare and fire-based healthcare. That's as far as approach goes. Huge, huge difference. I think that people who are more tactical, like firefighters, tend to think about tactical things and logistics and operations. And the healthcare that they provide is simply another tactic or a logistic or an operation. And they want a rhyme and a rhythm and a flow to it, and they want things to happen in a certain amount of time, and they want to get moving. Obviously it's not true for everyone. People who are providing healthcare outside of a fire service or outside of that type of environment, I think tend to provide more holistic type of healthcare. And that's why I think that healthcare in the fire department should be happily divorced. Hey, brother, checking in from the Savannah area. Thanks for all you do for EMS. Thank you for that encouragement. I appreciate it. I would say that fire-based is not healthcare. It is emergency-based. That's kind of a nothing statement. What we do is mostly not emergency. Probably 70 to 80% of what we do is simply out of hospital or pre-hospital healthcare. You actually need to stop thinking about yourself as being an emergency healthcare provider, because you are primarily not. There are three paradigms of healthcare when it comes to first contact with a patient. That is the EMS, the emergency department, and urgent care. And you can lump the emergency department and EMS into one. So let's say emergency care, primary care, which is a physician, and urgent care. They are actually all providing the same service. They provide mostly non-emergent, holistic healthcare that predominantly serve as some sort of health screening for when there is any sort of health abnormality in a patient. And sometimes they perform emergency care. EMS is just better trained to provide that emergency care, but they hardly function any differently than people in primary care and urgent care do. So you really need to stop thinking yourself as an emergency care provider, because that's not what you are. You are a pre-hospital healthcare provider. How many times do I intubate a month? Well, I do pediatric and neonatal critical care transport, so our circumstances are a little bit different than they are with 911. And we have to do rotations in the operating room to stay competent, to establish competency, and that sort of thing. The way you ride the pony, you should star in a Western. How's being clever going for you? What is your solution to reconcile budgets? In many areas, fire is subsidized, but I just don't have answers for that sort of stuff. I'm not into that sort of thing, like operations and things like that. There needs to be an entire paradigm change in healthcare where people aren't begging for dollars to provide that out-of-hospital healthcare. And so the only way that you can address that is to overhaul the entire healthcare system. And I think that EMS needs to get out from under the Department of Transportation and under Health and Human Services. The problem I notice with combinations fire and EMS is the prioritization of one over the other. Yeah, I mean, there's services out there where Seattle Fire, right? King County's Medic One program. They are, I assume, competent at fighting fires, but they have one of the most highly functioning EMS systems in the U.S., so it can function properly. But that shouldn't be the rule. I mean, being a firefighter and a paramedic makes as much sense as being a firefighter and a seamstress. They have nothing to do with each other, and this isn't a third world country. We don't need to combine them for the sake of convenience. I love and respect EMS workers so much they came to my house one time because I had tachycardia. Well, I hope they took good care of you. How do we get the old-timers to realize we need to have that cool-down period after ROSC? It's going to require data. You just can't change a paradigm overnight. We're only getting to the point where people are not pushing back as hard against working on scene. Thank you for the follow there, Just. But we have fantastic data on survival when you work on scene versus survival when you transport a patient intra-arrest. We don't have fantastic data for the 10-minute cool-down period. It is essentially expert opinion that we should take a beat, evaluate and stabilize our patient, and give them a minute before we get them moving. I think one study came out that evaluated whether or not the 10-minute cool-down was effective, and there wasn't any change in survival, but that doesn't mean it's not good practice. I am in paramedic school. What's the best tips you can give me for success in school? Do your reading. Do your reading, do your reading, do your reading. Did you hear me say do your reading, do your reading? You should have 2 reads of a chapter before you cover it in class. Because here's the thing, the classroom, that's not for learning new information. You shouldn't be hearing anything for the first time in adult education in the classroom. You're supposed to have read it prior to there and have it kind of spinning around in here, and you're supposed to be chewing on it a little bit and kind of shaking the questions to the top. The classroom is where you refine that information. So you should get 2 reads of that chapter before you cover it in class, then 1 more read after the class, but before you test. If you do that, you will do very well. Wait, did you say Kent County? I used to work there. Guess what? I was born in Butterworth Hospital. Fire is the jack of all trades, master of none. You have to be able to show up for any 911 call. I think it makes sense to have fire medics. It makes sense for some areas to have fire medics under our current healthcare paradigm and currently the way that pre-hospital healthcare and fire is budgeted. There are communities that simply could not mount an effective EMS program without combining it with fire service. Outside of that, in the modern day, it does not make sense to have fire medics. None whatsoever. Very confused on ventricular fibrillation and pulseless VTAC regarding medications to give. Why the change? What change are we referring to? Because they are approached exactly the same from a medical standpoint. They're both given epinephrine, and they are both given antidysrhythmics like amiodarone or lidocaine. The only difference I could see is when you're thinking about your H's and T's. Maybe, you're VTAC is polymorphic VTAC, and you suspect maybe that it might be torsades, you suspect that the patient ran a marathon right before they went into cardiac arrest, then you might give MAG in that situation. Or, you're a service that's trialing esmolol for ventricular fibrillation, but other than that, they aren't treated any differently. And you don't alternate epi and amiodarone. After the first defibrillation, you should be administering your epi and or your after the first defibrillation, then you start thinking about your antidysrhythmics like amiodarone and lidocaine, and you give your 2 doses. But it's not epi and then your antidysrhythmic and then epi. It's epi and your antidysrhythmic, then epi and your antidysrhythmic. Hello, Bossy. Bossy's out there with her lip gloss on today because it's her husband's birthday. So happy birthday, husband. What about torsades and no MAG? So here's the thing about torsades. You actually cannot differentiate torsades from polymorphic VTAC unless you had a 12 lead prior to onset that demonstrated there was a prolonged QT. Without that, all you know is that you have polymorphic ventricular tachycardia. You cannot say whether it's torsades or not. So it's really going to be history taking. Does something contribute to a suspicion that they may be hypomagnesiemic, such as a whole bunch of exercise or exertion or dietary deficiency? So that's what should be steering you towards magnesium. Yeah, epi and antidysrhythmics are not alternated. You give epi and the antidysrhythmic. What were the highlights of Crash and Learn? I've been waiting to hear more. Oh, I've got a whole bunch of stuff recorded. The one that I'll start, and I'm probably not going to put out too much between now and Sunday because it's the weekend and I don't want that stuff to get lost, with lower views. But the one thing that I really came away impacted by was resuscitative hysterotomy, which is when the mother is somewhere between 22 to 24 weeks, goes into cardiac arrest, and it's basically understood that mother cannot, you cannot achieve an adequate coronary perfusion pressure in that patient because they have this extra circulatory volume, and you're going to get blood lost in that area. And so you essentially perform a resuscitative hysterotomy where you retrieve the baby in order to rescue the mother. There is no intention to resuscitate the child. It is to retrieve the baby to save the life of the mother. If your service doesn't carry MAG? Wow. So you have pediatrics who are asthmatic and refractory to bronchodilators. You don't have MAG. You have a female with eclampsia who's in seizures. You don't have MAG. Shame on your service. MAG is a basic part of the paramedic toolbox. That is absolutely just disgusting. It is heavy stuff. And there was a mannequin there too, a very lifelike mannequin with a very lifelike operational sequence that delivered a very lifelike baby in a full amniotic sac. It was wild. Does your service have mechanical CPR? Stork 865. Okay, sell all your mechanical CPR machines and buy MAG. Your priorities are out of whack. MAG and ketamine are the Swiss Army knife of paramedicine. Yeah, it's actually surprising how essential MAG is to so many things. There's actually data out there that demonstrates that when you administer MAG with some other life-saving medications, that it actually assists in the effectiveness of those medications, including ketamine. You have levo too. I mean, if you have I'm glad that you have levo, because that would be your preferred pressor in sepsis, which you will see far more often than you will cardiac arrest. So that's fine. Do you have at least 4 or 5 people on your cardiac arrest scenes? Okay, yeah. Sell your mechanical CPR and get MAG. My service thinks proximity to a hospital determines what we need and don't need. Well, your service is wrong. Your patient needs what they need right there and then. Is there a time where you have to evaluate the time? Is there a time where you have to consider how long it's going to take you to perform an intervention versus the benefit that that intervention is going to provide in consideration of your proximity to the hospital? Yes. But first and foremost, your obligation is to provide the intervention that your patient needs when they need it. And your proximity to the hospital has absolutely fucking nothing to do with that. Well, I mean, tell me what you're going to leave off the table because of your proximity to the hospital. That's the discussion I'd like to entertain. Let's consider, I don't know, a corticosteroid like Solumedrol or Decadron. Are you going to say, well, I'm this close to the hospital, so I'm not going to give either? Okay, well, the earlier you give those things, the more of a likelihood you are going to prevent your patient from being admitted, or you're going to reduce the amount of time they're admitted. So you're just going to skip it? Or are you going to say, I don't care, I'm close to the hospital. I don't care if you spend 2 days in the hospital. We don't even have fluids in anything larger than a 500 bag. And that's great. That's buying fluids in liter doses is kind of a waste of money. Adults rarely need a liter of fluid pre-hospital. Do your albuterol, Duoneb, and Solu, even if you're across the street. Yes. Patients like to breathe, so do all those things that help them do that. Layman here, how is this stuff not standard? How much time do you have? "150 years of tradition unimpeded by progress." Pain management, that's the thing that really bugs me, is withholding pain management. If your patient's in pain and they have to get into an automobile and you have to drive, then that's the thing that's going to exacerbate their pain the most, which means that it's indicated prior to getting going. This nonsense that's being drilled into us about reducing scene times, that's about money. That has to do with your service wanting to get you back in service, and it's poor patient care. I'm going to say that again. You guys can edit this and you can show it to your services. And I'm very happy to point a finger right at your service and saying that if you're encouraging your people in your service to avoid interventions because of proximity to a hospital, you're bad and you should feel bad. Because we know what your motivations are. Do better. Excuse me. People give too much saline or ringers when it's not a volume issue, and pressors would be better. No, I mean, so it's not binary, right? It's not pressors or isotonic crystalloids. And it really depends on what the pathology is. Like somebody that's suffering from hypovolemic shock secondary to trauma, they need blood. It's reasonable to start with fluid, but they need blood, right? But we have to remember with pressors that in hospital environments, they're very careful about administering pressors through a peripheral line. It's not harmless. You can actually do pretty significant damage to a patient by administering a pressor through a peripheral IV line. And so they're very careful about that. And it just depends on the pathology. Someone who is septic needs volume and they need pressors, and you probably should be prepared to start pressors early, even if you're starting volume. But it's not binary. Sometimes they need both, sometimes they need one, sometimes they need the other. But, you know, if you can administer like 250 milliliter aliquots to somebody that's, you know, a little bit low on volume and get their MAP up above 65, you might not need to administer a pressor. And I'm not going to say that about somebody who is septic, because a MAP of 66 or 67 still pretty low. We want to get that up in that septic patient. But you know, you can bump people towards a good blood pressure with fluid. It just depends on what the pathology is. Is there any case you would choose lidocaine over amiodarone in cardiac arrest? Not really. The evidence for one over the other is not strong. So, in fact, I think there's barely evidence for either one of them in cardiac arrest. But I think it nudges towards amiodarone pre-hospital. So, where I am, we have to consider 2 liters of fluid before levo being considered. That is ridiculous. If you are into a 2nd liter of fluid on a septic patient, you should have set up fluids already. I mean, pressors already. That doesn't mean that they don't get the fluid. I was in a discussion with Dr. Peter Antevi, the developer of the Hantevi Hand and the Hantevi pediatric system and all the software and everything about this. And he said that fluid is to sepsis what blood is to trauma. They need that fluid. They're not low on blood, but they are low on fluid. They need that fluid back into their system. But you shouldn't be holding off on the pressors. I mean, for the amount of time it takes to administer 2 liters. What's something cool you learned at Crash and Learn? Something that I wasn't aware of is that that neonatal resuscitation guidelines we've all heard about performing compressions on pediatrics once their heart rate drops below 60, right? Well, it's actually not recommended that you do that unless you have an airway established and are actually oxygenating your patient. So if you are not providing any sort of oxygenation to your patient, then you shouldn't be starting compressions, because you're not circulating anything with those compressions. Just unoxygenated blood. What's my opinion on using the Eligard in cardiac arrest? I recommend that you not, because there's just not any data yet to support it. Now, if you're involved in a trial or something like that, that's one thing, but don't go out and spend the money in the Eligard right now. We haven't gotten any good data back on that. The last trial that we had, not only did it not demonstrate that it didn't lead to increased survival, but it was demonstrated that the authors were data dredging, not necessarily purposefully, but they placed a greater emphasis on data that they liked and a lesser emphasis on data that they didn't. There's a trial ongoing in the UK right now in the Eligard, and that will be a little bit more informative. My thoughts on pre-hospital blood: we should be using pre-hospital blood. The data is inarguable that pre-hospital blood saves lives. And that is both rural and in urban environments. What if you can maintain an airway with a BVM? Well, then you've established an airway. I decided not to apply to service because they don't allow anything other than normal saline for sepsis. I mean, yeah. I mean, that's a lot of services, are being stingy with the ringers, or they don't even carry it. And DKA, yeah. We put them in service last October at your department. The Eligard, God. How would we store blood in the ambulance? In a little cooler. Refrigerator. There is no reason right now for a service to be spending money on the Eligard. It's not evidence-based. Your patients are not your personal experiments. And I cannot, the only way that you can be spending money right now on an Eligard is because a salesman got to you. You're not buying used cars here, and your patients are not your experiments, okay? It's a waste of money right now. There are enough services out there right now that are using these things where we can start getting some better data through RCTs after a time. But outside of that, we're having a hard enough time with how we're spending our money EMS than to be spending it like that. And if you're not actually training your people on how to perform high performance, high quality CPR, then that's even a bigger waste of money, because you're looking at that device as some sort of panacea. And that's not the way that things work in medicine. Focus on training your people. The amount of money that you're spending on the Eligard, which is in addition to the cost of the Lucas because they have to be used together. We're talking $30,000 at this point, somewhere around there, for one of them. Do you realize the training you could be providing your people on how to perform a frickin' bang-up resuscitation by reallocating that money towards that training? It blows my mind. And what will happen is the Hawthorne effect will take place. The Hawthorne effect is when people perform better because they're enthused about something or they know they're being watched. So what will happen is you'll get this Eligard device and you'll see survival rates jump initially because people are very enthused about this new thing, and then it'll level back down. The problem is we have not enough blood, and not so many calls require blood. I mean, no practice is monolithic, meaning every service can't apply every single thing out there, right? It has to work for what they're doing. And every service may not, at this point, be able to resolve the logistics when it comes to blood. But you're not going to resolve it if you don't try to resolve it. You should do a bit about epileptic versus non-epileptic seizures. I mean, it would really only be to inform people about the differences between them as far as what originates. Generally speaking, they're going to be approached the same in the field. Lucas and trauma patients, I had someone say we cannot use it on traumatic arrests. That is correct. You should not be using mechanical CPR in traumatic arrest, and you should follow your local protocols, follow your local protocols, follow your local protocols. You should not be leading with CPR in traumatic arrest. ACLS and compressions and epinephrine, that is for people who have suffered out-of-hospital cardiac arrest from some sort of medical etiology. And it implies that they have an intact circulatory system and adequate volume within that circulatory system. In the absence of an intact circulatory system and adequate volume within that circulatory system, compressions are, for all intents and purposes, contraindicated, because you're going to exsanguinate that person with those compressions, or at the very least not do anything productive. So there's other things that you should be leading with in traumatic arrest. We premix our dopamine. Dopamine. Please just throw your dopamine out. Please. Please. I know you have epinephrine, okay? Just throw away your dopamine. Have parties where you throw away your dopamine. Here in Arkansas, we carry O positive blood. It's a lot easier to get than O negative. Yep, low titer is what that is called. If you're not familiar with low titer blood, O positive is one of the most common blood types in the world. O negative is not so common. It's one of the least common ones. And so trying to stock O negative blood is like impossible. It's just too many logistics. It's hard to get. But it's very easy to get O positive blood. People will have very severe reactions to the A and B blood types, and immediate reactions. But the Rh factor is much easier to manage. So if you give somebody that doesn't have Rh antibodies, Rh blood, you can still resuscitate them with that blood, and you can deal with the reaction to it later in the hospital, because it's not immediate and it is manageable. So that's why people use O positive blood. To me, the goal of Lucas is easier CPR without regard to whether or not the CPR is better. I don't disagree with that. It's more complex than that, but yeah. Just finished my NREMT 20 minutes ago, finished at 80 questions. That bodes very well for you, my friend. Have I ever heard of intranasal epinephrine for anaphylaxis? Yes, it is a relatively new thing that's happening, intranasal epinephrine. There's also a sublingual form as well that's being developed. I wish we could get away from dopamine. You and me both. The notion of that we're still using dopamine is just absurd. There is nothing dopamine does that another pressor can't do better. We are behind also. We just got a new medical director and he's redoing protocols. I mean, you could make a dirty epi-drip and that would be better than dopamine. A dirty epi-drip, follow your local protocols, is when you take a bag of saline or ringers and you just put a milligram of any concentration of epinephrine in there. So 1 to 1,000, 1 to 10,000. And then you just open it up until you get the blood pressure you want. Love your videos. Keep up the good work. Thank you very much. RSI versus DSI. I'm always going to say this when I get questions like this. That's binary thinking, which is when you reduce a discussion to only two possibilities. And I will get into what DSI, well, I guess I'll get into DSI since someone's asking what DSI is. RSI is rapid sequence intubation. DSI is delayed sequence intubation. RSI is when you administer a sedative, you administer a paralytic, and then you intubate. Just like that. Delayed sequence intubation is when you pre-oxygenate your patient with a non-rebreather and a nasal cannula, or even CPAP or BiPAP, and you allow that person to build up a reservoir of oxygen prior to intubation, and that avoids them crashing during the intubation, and it's very effective at doing that. There is a wealth of data behind that practice. Somebody experiencing an episode of hypoxemia during intubation significantly increases their likelihood of dying. So you administer your sedative, preferably ketamine. You start oxygenating that person, give it a couple of minutes to build up that reservoir, and then you administer the paralytic and intubate. Now, when I say it's not binary, what I mean is that one is not necessarily better than the other, because if you have a crash airway and you have lots of fluids involved and all sorts of stuff, you may just have to sedate, paralyze, and intubate, just like that. But generally speaking, it's better to resuscitate before you intubate. So you build up that oxygen reservoir. You have push dose epi ready. Sometimes people actually administer push dose epi right before the intubation attempt, so they also don't become hypotensive, which is also associated with mortality. So that is the difference between RSI and DSI. The question is, what sort of patient do you have in front of you? From what I hear about Arkansas and their protocols and practices, it's not good. If my service has only 10 and 60 drop sets, is that not a broad enough selection? No, that's all you need. Improving the improvable first. I love the way that's phrased, yeah. Pregnant female in cardiac arrest. Would you load and go as you're worried about saving the baby? I don't think the problem is we don't have any universal practices when it comes to maternal resuscitation. So I'm not going to wade in there. I actually, that's been on the front of my mind because I went through a demonstration this weekend of what's called resuscitative hysterotomy, which is when EMS personnel actually surgically remove the child so that the mother doesn't have to contend with the fetal circulatory system during a resuscitation, which is an abortive procedure. It is done to save the life of the mother, which is your first priority. But I don't want to speak to what you should be doing in that situation. I just think that I need to have more discussions with experts on that. I work at a blood center. Do you carry whole blood? It's becoming more popular in EMS. Well, I'm a hospital-based system, so if we are dispatched to any call that may require blood, we stop at the blood bank and grab it. Do you have a 100 milligram injection of hydrocortisone with you on shift for adrenal insufficiency? We have Solucortef. Kentuckiana Safety Solutions, yes. Well, no. Resuscitative hysterotomy is an abortive procedure. You are removing a child somewhere between fetus between 22 to 24 weeks in order to save the life of the mother. And you are not performing any resuscitative efforts in that regard on the fetus. This is graphic, but you are delivering with the intent to discard the fetus, and the training is to make sure that you get the fetus into something so that it's not visible to the public or to anybody around you, like a bag, But you essentially are rapidly and surgically removing the fetus, performing procedures to basically like tourniquet the uterus so it doesn't continue to bleed, in order to reduce the circulatory capacity of the mother and reprioritize circulation to the heart. GSW to the chest, whole clip, 16 rounds, asystole on arrival. Would you work him? I mean, that sounds kind of like an injury incompatible with life. I mean, if your patient is a colander, there's not much that you can do there. We don't hang blood, we pump it with a device. Use the life flow. What are my thoughts on interfacility transport? I don't know. I mean, someone's got to do it. I mean, I do interfacility transport technically because I do neonatal and pediatric critical care transport. But we operate at a pretty high level and perform a lot of advanced interventions. What are your thoughts on services that don't carry paralytics? Well, they usually don't carry it for good reason, which is that the people that are working for them are not very good at intubation. So the question really be, what are your thoughts on services that don't maintain the competency of their people in intubation? Because that's what it comes down to, is that, the only time these people see intubation is in cardiac arrest. They don't go to the operating room and get their reps. They're very rarely having to intubate somebody outside of cardiac arrest, and so their services just aren't doing enough to train them. If you were to train your people, get them reps in an OR, at the very least, every day they have to pass a tube through a mannequin, which is valuable muscle memory, then you're never going to get to the point where they can be good stewards of a paralytic. Do EMTs always check for medical bracelets? They're always supposed to. They're supposed to check it. That doesn't mean that it always gets checked. There's adrenaline is running high on scenes, but we're supposed to be looking for those sort of things. Thank you for the follow. I've never missed with the eye gel, right? Looking to start a fire, police, EMS mental health channel. Then that's great. There needs to be more efforts on talking about those sort of things. Managing defibrillator going off and patient in and out of lethal rhythms. Can we still give meds? I mean, if they're pulseless, yeah, you just treat it like a cardiac arrest. Eye gels have almost the same success as an ET tube. I don't know what that actually means. What are you defining as success? You mean so you're asking me if somebody's implanted cardioverter defibrillator is cardioverting them over and over, right? Internally? Okay, because defibrillation is different. That is, defibrillation is when you are applying electricity to somebody who is in a pulseless rhythm. So this is somebody who is in some sort of rhythm, but they have a pulse and they're being internally cardioverted. In that case, you would administer them the appropriate medications that would hopefully mitigate those rhythms so they could cease to become, so that they're not internally cardioverted anymore. At the very least, well, in addition to, it would be kind of you to administer a sedative to them. What do I think about AED versus manual defibrillation? Thinking about errors made by EMS. I need you to tell me more about what you mean by that. Is where you're coming from with this kind of a thought experiment where instead of manually defibrillating patients, we just put our monitors into AED mode and have the monitor analyze? Thank you, I appreciate that. Okay, so that's where I thought you were going with that. So a defibrillation effort that extends a perishock pause. A perishock pause is the amount of time it takes you from hands-off to defibrillation. Extending your perishock pause more than 5 seconds reduces the likelihood of survival or a successful defibrillation by 20%. Think of how long it takes for an AED to analyze and then charge up and then shock. That is an unacceptable amount of time. And what we should be teaching people is to have a low threshold for defibrillating a patient. Like, remember that what you want to do is pre-charge your cardiac monitor before you reach the end of your compression cycle. So you're about 15 seconds away from your rhythm check. And so you charge your monitor, right? So you're approaching the end, you're doing compressions, and then hands off, you look at the monitor. Is it shockable? Shock. That's it. That's how quickly it should happen. So it's like this. Somebody's compressing, somebody's at the monitor. They let go. The person who's at the monitor should shock as soon as they identify a shockable rhythm. And if they're having trouble identifying whether it's shockable or non-shockable, then it's shockable. And so think of how much time that takes. Hands off, shock. Hands right back on. That was 2 to 3 seconds right there, max. Now think of the AED being on there, okay? So you're approaching the end. Place your hands off the patient. Analyzing. 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 Ooh. Shock patient now. Boom. Compressions. That's a death sentence to some patients. So no, we should not be doing that. No longer than 10 seconds for a pulse check. Well, a pulse check happens prior to initiating resuscitative efforts. We don't perform pulse checks during a cardiac arrest. And we're actually encouraged not to spend 10 seconds looking for a pulse even at the beginning, because the data demonstrates that we are really, really bad at identifying a pulse in a short amount of time. Where I am, it is illegal to manually defibrillate. We could go to jail for it. Okay, so you're asking me as a bystander, I'm assuming. Oh, you were asking me before. I think you are a bystander, aren't you? I mean, a bystander doesn't have access to a manual defibrillator. You just use an AED. Of course. No one is allowed to use a manual defibrillator without being a licensed healthcare provider working under protocols. Or they aren't ALS. But even like some BLS crews are allowed to manually defibrillate. You should get 30 compressions while it's charging. You should get 30 compressions while it's charging in between the analysis and shock. That is way too long, man. That is way too long. Wait, what? How do you cannot analyze a rhythm during compressions? I have no idea what you are talking about. Now, like the Zoll monitor has that see-through CPR, but that technology just isn't proven yet. Are rescue breaths the meta or are they outdated? They are the most associated with survival when you don't have an advanced airway placed, or 30-2 compressions. But there's a high training threshold for that. There was a study that demonstrated that 30-2 compressions were more effective than continuous compressions or upstroke ventilation. But what the study acknowledged is that 30-2 compressions was very difficult for crews to do well. So you're doing your 30 compressions, right? And then you reach number 30 and you stop. And what happens? The person provides 2 ventilations and the person who is compressing waits. So it's like this. They're providing 1, exhale, 2, exhale. You might have actually lost all of your intrathoracic pressure during that time, because it only takes about 3 seconds to lose all that pressure you built up, which means it's going to take somewhere between 10 to 20 seconds to regain all that pressure and start perfusing your heart again. So that could be a very deadly amount of time that it's taking for somebody to provide those ventilations. The compressor should be resuming their compressions within 2 seconds, whether the ventilator provides 2 ventilations or not. So there needs to be a very well-trained crew to provide good 30-2 compressions. Please do not take 10 seconds to do a rhythm check. Please do not take 10 seconds to do a rhythm check. That is a death sentence to a patient, okay? Please, just know there's a meme about Ron Swanson in Parks and Rec walking through Home Depot, and one of the employees comes up to him and says, "Can I help you?" And he says, "I know more than you." I know more than you in this regard, okay? I guarantee you that I do. If you are taking 10 seconds to do a rhythm check, what the hell are you actually doing during that time? I'm serious. What are you doing during a rhythm check that takes 10 seconds? It's either shockable or it's not. If it's shockable, it's going to be VTAC, and that's very recognizable. If it's, or it's going to be VFib, which is very recognizable. If you're looking at like this and going, is that VFib or is that not VFib? Well, then that's VFib until proven otherwise. It is much better to shock that rhythm rather than miss an opportunity to terminate VFib. Follow your local protocols. You're getting Lucas devices next month, and I'm very excited. Why are you excited? Lifepack35 says their see-through CPR is more advanced than Zoll's. Well, we'll see what happens once it gets out into the wild and we can do studies. Thoughts on CPR with the rescue pump and pod. No data to support the use of what's called rescue CPR with the rescue pump and the rescue pod. That rescue pod is like gum stuck in the bottom of our shoe. We have no data to support the use of the rescue pod. And rescue pod is used with the heads up CPR as well. Hello, Brick EMS. Or just shock them without anything if they have serious signs and symptoms. Please do not do that. Right. No, I know you're saying no longer than 10 seconds, but you shouldn't be saying that because you're building a mental process in someone when you say something like that. You should say no longer than 2 to 3 seconds because that means you're going to be training your people to do a rhythm analysis in 2 to 3 seconds. They should feel the pressure to do that in 2 to 3 seconds. When you tell them, well, don't take any longer than 10 seconds, well, then all the pressure's off, right? I got 10 seconds to do this. You have to build people's mental processes. And if you're giving them an unacceptable amount of time to do something, they're going to do something in an unacceptable amount of time. If you tell them what the time frame is to perform critical interventions, then they will train to perform those critical interventions in that specific set amount of time. Please don't waste time with pain meds. If they have a rhythm that is not compatible with life, well, again, this is binary. This is a binary discussion. And I've missed some of this, but I'm assuming that this is a conscious, alert, and oriented patient who you're about to cardiovert, do a synchronized cardioversion on. There are patients who probably you shouldn't waste your time with administering an antidysrhythmic and they need to be cardioverted sooner rather than later. But you probably could take a minute and give them something for that. Then there are other patients who, they're just shitting the bed right in front of you and you just need to do it. I've had a couple of patients where I'm like, listen, we're just going to have to do this, okay? And, it happened, and, they were mad about it for 1 second, and then it was over. But it's not binary, okay? Try to avoid looking at things in an entirely binary way, and learn to look at your specific individual patient and tailor your care to them. What if you need to do transcutaneous patient and cannot gain capture? What's your choice of pressor? I would probably experiment with the pressor before I went with transcutaneous pacing. It really depends on how stable they are, but my choice of pressure would be levo. Can you do a video on recognizing cold sepsis? I think I do have a video looking at cold sepsis and warm sepsis. Cold sepsis and warm sepsis is essentially the way the sepsis is affecting the circulatory system. Like, you can have somebody who's warm and pink and who's vasoconstricted. They just don't have great cardiac output. But, they'll have good cap refill, and maybe they'll have a blood pressure like 80/40 or something like that. That would be considered warm sepsis. But there's other people who are kind of like decompensated, and it's really about compensation. You'll have people who are decompensated, so they're vasoplegic, they're not compensating anymore, so they have cold extremities, that sort of thing. That would be cold sepsis. I was charged the defibrillator before a rhythm check. There you go. Where do you stand on AEDs that analyze whilst compressions are ongoing? I don't know that there is a body of evidence demonstrating that they do that well. We appreciate you, bud. Keep up the strong work. Thank you, Brick EMS. I appreciate that. We'll be at the EMS Pro Expo in Connecticut in October. I don't know what that is. I'm going to... Oh, it's a fire and trade show. Okay. Interesting. I will not be in Pittsburgh next week. No, not planning on traveling until November, when I'm going to be possibly at the Nebraska EMS conference. No, it's not horrible not to give pain meds to somebody you're going to cardiovert. Remember, a lot of pain meds cause hemodynamic instability, right? Unless you're using something that is hemodynamically stable like ketamine. But for some people, a lot of times the go-to is Versed. Now you have to contend with that benzo afterwards, right? And I've had plenty of patients where we've just gone ahead and just done the cardioversion, and, they didn't like it, but, it was over, and then that was it. Us at Hardin County EMS love discussing your videos. Hello, Hardin County. Thank you so much. It's great to hear that. I love knowing that my content is provoking discussion. So thank you, Hardin County. Do I travel to other services and teach? I've been invited to do that, and I have done that in the past, yes. All you have to do is invite me. Oh, TikTok is making me solve a puzzle to ensure that I'm still here. And all you have to do is just send me an email, Jimmy at EMS Avenger, and we'll look into see if that can work. Arkansas might be doable because, that's not too far away from Georgia. That's probably the only thing that would get me to come to Arkansas. Would you work up angioedema from lisinopril reaction the same as anaphylaxis? No, it does. It doesn't respond well. That's just not the way that angioedema is mediated for a lisinopril reaction. Well, I think you mean to say antigen, but correct. It doesn't quite work the same way. I would love to get you here. Arkansas needs help. Yeah, anytime somebody tells me about a practice that they have in Arkansas, I'm just like, oh, that's not good. I don't want to condemn Arkansas as a whole, but so far, I haven't heard from somebody telling me about progressive practices in Arkansas. I live in Georgia, where this is also the case. We are not a progressive EMS state. You stay safe as well there, Brick EMS. Appreciate you. In a busy system with little to no help from fire, should the EMS system stay dual medic? No, I mean, that is a luxury of riches, having a dual medic truck. And it's in this day and age, it is hardly a valuable use of resources. Seriously. So with angioedema, just supportive measures, support airway and emergent traffic. Any treatments? You would want to be very aggressive with that airway. If it's severe angioedema, you want to get that tube in there before you're not able to get that tube in there. Follow your local protocols. What are your thoughts on carrying antibiotics on the ambulance for rural? There's data to support the use of pre-hospital antibiotics, but it has to be, the crews have to be trained in sepsis recognition. And there has to be a consideration to creating situations where we have antibiotic resistant pathogens, right? So, there has to be a really stellar training program to accompany this. It's not just, I think this guy's septic, let's give him Rocephin, right? It can't work like that. So people have to be trained to recognize sepsis. They have to be trained to recognize how far gone this person is. You get someone who, they have a temperature of 101, and they're maintaining the blood pressure relatively well. They might need a little bit of a fluid bolus. You suspect sepsis. And any reasonable person might be suspecting sepsis, but it's not screaming, sepsis! And you're 5 minutes from the hospital, or 15 minutes from the hospital. It might not be in that patient's best interest to start a broad spectrum antibiotic. But you're only 10 minutes from the hospital, but this patient has a temperature of 104 and a blood pressure of 60/40. It's imperative that you start a broad spectrum antibiotic. So I'm in favor of it for any pre-hospital provider as long as they have a strong sepsis recognition program. Starting paramedic class next week, any tips for a 0 to hero EMT? And somebody has replied to you, get experience as an EMT first. 0 to hero, right here, 0 to hero. My first job in EMS was my first paramedic job in EMS. And that's simply because I could not afford to work as an EMT. I was an electrical contractor making a career switch, and I could not afford to make the switch until I was a paramedic. It is entirely dependent on what type of person you are. It really is. If you're going 0 to hero and you have been skating through your EMT courses, you just are really good at taking tests, but you're not really putting in the work, please do not do that. Please do not skate through your paramedic course. But if you're going to put in the work, if you're going to put in the blood, sweat, and tears, you're going to pick up the time, you're going to do the reading, you're going to do the studying. If you're wired like that to put that into practice, there's no reason why you can't do that. We'll go a couple more minutes here and I'll probably end it. I need to start. Well, no, there's actually nothing I need to do, but this is my only day off between coming back from Montana and working tomorrow. So thoughts on nitrous probably, for non-opioid analgesic care. I want to try to get my department on board. I'm not a really big fan, and that's because it's very expensive. It's and fentanyl is not. You want to have a progressive pain management protocol, then get IV Tylenol. New medic, I feel like an imposter. However, my partner and coworkers say I'm excelling. How do I stop it? You have to lean into it. I've suffered from imposter syndrome my whole life. I have been terrified my whole career that I don't know enough, and that any minute people are going to say, this guy is so full of shit, he doesn't know anything. I'm going to live in constant fear of that. And so I've just basically harnessed that into a motivation to keep doing better and to keep learning more. Is the pain meds for undiagnosed abdominal pain a myth? Yes, it is. It is based on a very, very old textbook from over 100 years ago that said that if you administer an opioid analgesic or analgesia to someone experience undiagnosed abdominal pain, that it'll obscure the diagnosis. That text was later amended to say that it was actually unethical and immoral to withhold pain medication from these patients. And we've had multiple subsequent studies since that demonstrates that not only does administering analgesia to patients experiencing undifferentiated abdominal pain not obscure the diagnosis, but it helps clarify it. We are just now getting a protocol letting us get pain meds for abdominal pain. Good. I remember when North Carolina, this is about 14 years ago, 15 years ago, that's where I was living at the time, they updated their protocols to have statewide protocols, and we had analgesia on standing orders, including narcotic analgesia, and it specifically said, do not use that. Abdominal pain is not a contraindication to pain management. I'm based out of Georgia. So I think I'm going to go ahead and community paramedic or EMS physician. I mean, get all the education you can. So shoot for the moon. I'm going to cut it off here. I want to relax a little bit before my girlfriend gets home, and I have to go into boyfriend mode. I have to get into boyfriend mode. So appreciate you guys hanging out during the live. It was fun hanging out, and I've been trying to get live as often as I can, and we'll do this again soon. We'll see you later.